Okay, so welcome to everyone. Um, Last week I did a bit of an overview about what cooperatives are all about, and I took one success story, which is actually a few hundred cooperatives that formed a movement in the north of Spain. So the name of that movement is Mondragon, and they literally consist of nearly every single industry you can think of, whether it's medicine or automotive, insurance, banking, education. Uh, they have basically used the cooperative form to establish these various businesses. So one of the forms one can use is a health cooperative. Now, according to the United Nations, during 2018, there were 3,300 health cooperatives worldwide, with a turnover of 15 billion US dollars, servicing 100 million families in 76 countries. So there's a nice visual representation of the countries where you can find health cooperatives. Now, these health cooperatives can take different forms. It could be a worker cooperative that is owned by doctors, or it could be a user cooperative owned by the patients, or an investment cooperative owning hospitals or assisting doctors to finance capital intensive equipment. And we actually have an example in South Africa, Coop. They based in Cape Town, so their members are medical doctors, and as you might know that equipment like MRI machines and sonars and all of this is highly capital intensive. So this is the vision that Medicope has, is to help their members who are medical doctors to self-finance their equipment. Then you also have production cooperatives in the pharmaceutical industry, and then multi-stakeholder cooperatives like the Skias Cooperative in Spain. So they would actually be a combination of all the above. They would own multiple hospitals, doctors, and members or users are the shareholders. They will also have some involvement with research and development and the pharmaceutical industry. So you can see worldwide, this is actually not small at all. So what are the goals of a health cooperative? Well, first, it is to bring together users and medical professionals, and then to reconcile the misalignment between supply and demand. Also to jointly manage cost and risk, and to provide as an end product quality care provision. So the challenges that we have today in medicine is that people have a longer life expectancy, and together with that, chronic conditions need to be treated for a longer time. So that means that whether it's national or private healthcare systems, financially, they are not sustainable. So in South Africa, we're having this whole discussion about national health insurance, which would be a universal type of health care. So, the positives that are usually highlighted is that the overall cost of healthcare in an economy will come down. So if you look at countries like Denmark, that is definitely the case. It also forces hospitals and doctors to provide the same standard of care at a low cost, and it eliminates administrative cost by eliminating the need to deal with private insurance. On the negative side, however, it forces healthy people to pay others medical for others medical care, Without financial incentive, people may not be as careful with their health. And most universal health systems report long wait times for elective procedures. So anyone that has lived in the UK, for example, will know if you need to see a dentist, there are waiting lists. You wait. You can't just step into a dentist's office and get your treatment. There are waiting lists. Um, so cooperatives or health cooperatives uh, address these problems in the following way. These cooperatives are member owned and they are not primarily profit driven. So with national health systems, there are often corruption problems. And this is one of the big, and I don't think it's just a fear, I think it is a reality with the proposed NHI. If we look at the state of other state-owned enterprises like ESCOM or SAA, there's a lot of corruption taking place. And I think it's reasonable to make the assumption that the same will happen with the NHI. And then when it comes to private systems, they are very expensive. So if you think of our medical aids, they are expensive. And one of the reasons for that is shareholders want their pound of meat. Shareholders are not going to invest in medical aids that are not going to give them a good return. So that's one reason why private healthcare is so expensive, because there are investors putting their money at risk funding these private medical aid schemes. A cooperative, on the other hand, is member owned, so there's less space for corruption. It's like, if you know, we see the same dynamic in the CFI, in gig CFI. Members think twice before defaulting on a loan, because they usually also have savings in the CFI and they have friends with savings in the CFI. So there's a loyalty factor. The same with a health cooperative. There's a loyalty factor that kicks in. So the space for corruption is much less. And then also, due to cooperatives not being primarily profit driven, there's a focus on reserves. This does not mean that cooperatives must not be sustainable. They must be sustainable. The difference, though, between a cooperative and a company is that in a company, shareholders pressure for dividends to be paid on their shares. In a cooperative, uh, uh, and this is applicable worldwide, there's a focus on retained earnings, so building up the reserves in the cooperative. Now, this has got some wonderful benefits. Last week, I explained how in worker cooperatives, in the Mondragon example, during economic downturns, there are basically no layoffs because salaries can still be paid due to the big reserves they have. And in health cooperatives, there's really an incentive to do research and development because there is reserves available. So health cooperatives really present an opportunity. This little map that you can see there, you'll see countries that don't have any universal care like America. This is quite a problem. People go bankrupt in America because of medical bills. So health cooperatives are quite popular in America. Okay, so let's look at what type of health cooperative could or would we use in South Africa. So drawing from some international examples, it really depends on the context of the country. And so a few examples. If we look at Argentina, they had a financial crash in 2001, and they've never quite recovered. Many hospitals were declared bankrupt, and these hospitals were revived by the doctors working in them. So they started cooperatives, and they basically took over. It's nearly like a worker buyout. So they cooperatized the hospital, if I could use that term. In Australia, we see the rise of multinationals, and we see this also in South Africa. Think about groupings like Intercare, where they group a whole lot of GPs and dentists together in one practice to get economies of scale. Those GPs lose their independence. And something similar has happened in Australia. But to counter this, GPs started to form cooperatives to reach some scale and efficiencies, but to still retain autonomy. In Brazil, their biggest health cooperative, Unimed, pays the healthcare professionals much better than the public sector. And they actually have 32% of the private market. So if you are a medical professional, you would rather be contracted or working within the Unimed system than for the state. In Europe, if we look in Belgium, since 1880, they have arranged or organized their pharmaceutical industry by using cooperatives. So today there's 616 pharmacies. I think it's about 30% of all the pharmacies in the country, and they are federated into 15 pharmaceutical cooperatives. And they have one aim, and that's to provide quality medicine at a good price. And they're able to do that, since profit is not their primary motive. In Canada, an interesting example, most ambulance services operate as cooperatives since the 1980s. It takes the form of worker cooperatives, so the drivers and the paramedics own the service. So thinking of South Africa, I think the way vehicles are driven, if it's not yours, then there's no incentive to look after it. And I think this would be a great model for South Africa, to have ambulance cooperatives. If the drivers know they're the owners, they will definitely look after the vehicles. And then in Japan, there's a cooperative federation, HEW. They consist of 111 separate health cooperatives with 75 hospitals, 2.9 million members, 70 dentist offices, 28 nursing homes, and close to 35,000 people working across the different cooperatives in this federation. And they focus on the elderly and specific geographic areas. There's another excellent example in Spain of a multi-stakeholder health cooperative, but we don't have time to go into a discussion about them. But this is just a few examples to show how health cooperatives are used in different countries. So what do you think will work in South Africa? I think one can get very creative. A idea is one of GIG's associate members, who's an actuary, once mentioned to us that if we have 3,000 plus members, that we could create something like a health cooperatives. And what you would basically do is every member gets free medical scheme quotes. Now, I know the medical schemes have each their own uniform premiums, but it is adjusted depending on if you've been part of a medical aid previously or not. But one would, for example, take the average premium for plans with similar benefits. And that would be the premium that the member would pay into the cooperative. And you're also going to split it between day-to-day benefits and hospital benefits. So your day-to-day benefits, you will finance out of the pool of contribution. So one example, there's many different financial models, but just to make it very simple, there's a health cooperative in America that uses this model. They would say, in a given month, all claims are paid in proportion to income received. So for example, let's say in a given month, there are 11 million rand in claims on day-to-day benefits, but only 9 million rand income that's now on the day-to-day portion of the premium. Then the members will be reimbursed 80% for their day-to-day costs. So members see this on their statement, and once again, because this cooperative belongs to the members, they won't waste or go to the doctor unnecessarily or take expensive medicine where there's maybe cheaper generics available. So there's an incentive for members to actually control their medical expenses. We all know how it is if you belong to a medical aid, you pay so much, and there's often the temptation to say, but I need to get something for all this money I'm paying. And this mindset makes medical aids inefficient and causes a rise in costs. Medical inflation is way higher than the normal CPI measure. And then your hospital type of events, emergencies, big ticket items, so they have usually a low probability but a very high impact financially speaking. This you would pass over to a reinsurer. So you won't try and cover this on your own reserves, except if the group starts to grow really big, then one can take this in-house. But for a start, one passes this risk on to a reinsurer. So this is just a very simple idea to show with the question we have about healthcare in our country. There are different stakeholders. So there are the users, those that need medical services. There are the medical professionals that are unsure about the future. And I think this is a great mechanism. If you look to countries that are similar to South Africa, for example, Argentina, although their situation is worse in many aspects, I think that when people come together, they can create their own solutions, and it's not all up. We don't have to depend on government solutions or national solutions. And often these health cooperatives even work very well in countries that have good universal healthcare, like Spain, for example. There is still a need for health cooperatives, and people prefer it because they get better service from the health cooperatives, although the universal healthcare is also good. So in every situation, it seems that there's scope for this form.